Hello everybody, Michelle Lyons back with you again, and for this episode of Meet the Experts I am delighted to be joined by my learned colleague and friend and really goddess of knowledge of all things electrotherapy, secretly a member of Thunderbirds when she's not doing pelvic floor genius activities, Ms. Fiona Rogers. Fiona, thank you so much for joining us today.
Thanks for having me, Michelle. It's always a pleasure chatting with you.
Just bear that in mind. So, Fiona, what we're going to talk...
There's my Thunderbird. Just got my tea. It's tea.
Sure it is. I believe you. What we're going to talk about today is the use of electrotherapy for pelvic pain. Because, as I've said, Fiona is really... You know, as Jenny Burrell would say, when you want clear water, you go to the head of the fountain. And anytime there's ever a question about electrotherapy, my first instinct is to reach out to Fiona, because not only does she have a fabulous website selling all sorts of electrotherapy goodies, but she has done the research and she's done the work, and she's got both hats on, from a clinician perspective and the research, and then knowing which unit is best. But Fiona shared a really interesting paper in the Global Pelvic Physio group last week about using TENS for primary dysmenorrhea. And that was really one of the reasons that I wanted to get Fiona on here again to talk about really the use of electrotherapy agents for pelvic pain primarily. So Fiona, what role does electrotherapy play in pelvic pain?
It plays a adjunctive role. I think we just sort of need to make that clear from the beginning. It's not a be-all and end-all treatment. It should always be an adjunctive treatment using electrotherapy. And when we're talking about it, we're actually, for pain, we're actually talking about TENS. So there is there's a lot of misnomenclature, if that's the word. People misuse the terms. You'll hear electrotherapy actually encompasses all types of EPA. But if we're talking about electrical stimulation, it's better to talk about neuromodulation. So we're trying to do an input to get a different output. So whether that be either a sensory one or a motor one. So generally the best way to think about it is that we use TENS to do a sensory input, and we use what people will term E-stim or STIM. It's actually neuromuscular electrical stimulation is the technical term to do motor stimulation if we're wanting to do muscle strengthening. So when we're talking about pain applications, we're actually referring to TENS. And I do hear it incorrectly, interferential is another term, and that is applied transcutaneously, which TENS is, which is transcutaneous electro nerve stimulation. But people kind of sometimes use those two terms, for each other, and that's not true, because interferential is a completely different thing. So what we'll be talking about here is actually TENS.
And I think as well, so at this point, it's worth talking just possibly about another of your bugbears, just for clarification, because you know this comes up every few days, it feels like. Can you just once and for all tell us the difference between TTNS and PTNS?
Okay. There was actually a really good paper that came out this year, Moretti et al., and they talked about nomenclature with the tibial nerve. So the tibial nerve is the tibial nerve, but you will often hear it called the posterior tibial nerve. So people will talk about PTNS and TTNS, and you're never really sure with PTNS, are they applying it percutaneously or transcutaneously? So they're trying to bring in the general term of PTNS being percutaneous tibial nerve stimulation, and TTNS should be transcutaneous, and not calling the tibial nerve the posterior tibial nerve, because it's the tibial nerve. But some people refer to it as posterior tibial nerve, so it gets very confusing. I actually have a little slide I use in my talks that, circles PTNS and TTNS, and it goes off at angles like this, and it sort of shows what a mess it is when we try and interpret the research.
Yeah, and it's, when we start going down this rabbit hole of abbreviations, I think that's where madness lies, isn't it? Because it's so easy to get into very confusing conversations very quickly, and like you said, even in the research. Just out of curiosity, in terms of efficacy, do you think PTNS, TTNS, who's winning?
If you look at the research, PTNS probably has more robust research behind it. You're getting more directly on the nerve.
Yeah.
TTNS is there's certainly a lot of really good, excuse me, a lot of really good research coming through, and some studies showing equal efficacy. But the real catcher there is TTNS. You can actually, the patient can do themselves at home. They can do it with a cheap little machine, and they can self-titrate it. It's they're you know, you're handing over the treatment control to your patient, whereas PTNS still needs to be done. If you're having it done by a urologist, it's really expensive. Some physios will do it using acupuncture needles, but they've still got to go into the clinic. There's still the extra cost. So, you know, there's a lot of really nice research coming through, and well done research on you know, the TTNS.
So, you know, I really do think that TENS is such an underused and underappreciated modality, because, you know, back in the early Victorian era, when I was in physio school, you know, we had quite an extensive electrotherapy module, but then it seemed to kind of go out of favor a little bit. And I feel like it's starting to have a light shone on it now again, because it's cheap, it's effective, it promotes autonomy and self-efficacy. And I think particularly for women who are struggling with pelvic pain, and I would say especially in the field of either dysmenorrhea or endometriosis, it could potentially have a much bigger role, particularly when you think about the side effects of opioids. Can you just maybe tease out, like, you know, how can TENS be used by a woman, say with either dysmenorrhea or with endometriosis? How do you see its role? I mean, I know you mentioned adjunctive, but can you just paint a picture for us?
Well, definitely as an adjunctive and as a neuromodulator. And you're quite right. You know, we talk about the opioid crisis. There's been an explosion of research done in the field of neuromodulation overall. So, you know, we're talking from TENS through to SNS implants, etc. So, they're, you know, obviously looking at other ways of managing pain. And certainly in the area of pelvic pain, you know, it's a really nice way of putting in some gentle sensory input to change what's happening centrally. Because someone with chronic or persistent pelvic pain, they're going to be centrally sensitized. And, you know, when we know with central sensitization, there's an increase in central excitability, and there's a decrease in the endogenous inhibition coming from the central nervous system. And what TENS does, it reverses that. So with TENS, you're getting an increase in that endogenous inhibition, which should lead to a decrease in the central excitability. So, and the other thing is there's two forms of TENS. Well, there's two ranges of TENS. There's high frequency and there's low frequency. Most of the research is pointing towards the high frequency being more effective when it comes to pelvic pain conditions. And they work on two different pathways. So one really important thing to be aware of, so when we're talking high frequency, we're talking 80, 100 hertz. That talks about the gate theory of pain. So essentially what you're doing is you're putting in a nice non-threatening sensory input into the nervous system, and that can prevent some of the noxious stimuli coming from the C fibers. It kind of gates it out. So what you're getting through is the nice, gentle pain up to the somatosensory cortex. And so that works on one form of opioid receptor. The low frequency, when we're looking at, so it's quoted between 1 and 4 or 2 and 5, sometimes up to 10 hertz. That's working on the mu opioid receptors, which are the same receptors that the clinical opioids work on. So a really important point to know is if you have a patient who is opioid dependent, or they're taking opioids for their endometriosis or their dysmenorrhea, they're not going to respond to the low range hertz. And they've actually done some really interesting research on that using naloxone to block some of the receptors, and it gets a bit complicated, I won't go into it, but they're basically showing that the high frequency is better with this sort of managing this sort of pain. So what we're aiming to do is to just put in that nice calming sensory input to help calm down or overtake the noxious input. And another point there too, even recent research papers and book chapters talk about pain messages going up to the brain. So we really need to distinguish that, you know, we're talking about noxious input, not pain messages going to the brain. So it's you know, to people who are working in pain areas, that's quite a basic concept, but you still see it in the research. You still see them talking about pain messages. Yeah.
So just in case, because, you know, we're hoping that a wide spectrum of people will be watching this, could you just, in simple language, clarify the difference between pain and noxious stimulation, that messaging from the output, from the periphery inwards?
In simple terms?
Well,
yeah.
relative.
Well, you know. So basically, as I say, pain is an output of the brain. So it brings in that whole threat response, etc. So, and that's also where I find girls with dysmenorrhea and endometriosis. Normally, when you talk about a persistent pain patient, we're talking about someone who's had a injury. Usually that has settled down or healed, but we've got that remaining hypersensitivity and pain response. When you've got, to my mind, when you've got someone with endometriosis or dysmenorrhea, every single month they're getting that injury, I guess you could call it again. So you may be getting a wind down of the central nervous system, but as soon as they have a period again, then they get wound back up again. So there's a lot of dips and curves with when you're dealing with endometriosis and dysmenorrhea in particular. So I think, you know, using something like TENS can be very empowering to women because they can use it to help self-modulate the and when they need it. So and we can chat about a couple of papers that have systematic reviews that have just come out along those lines in a minute. But yeah, so it's not like, you know, I've hit my hand with a hammer, that sort of pain. You know, that is a threat to the body. So you know, you'll experience pain. But once a person's in that pain cycle, the whole system becomes very hypersensitive. So things that would not normally set off the sensation of pain can more easily do it. It's like a dimmer switch. That's how I often describe it. And like a memory of the pain too. So the one thing that I always impress on my patients though is don't leave this consultation thinking that I'm telling you it's all in your brain. You know, we talk a lot about, you know, the brain experience and so forth. It's very real, the pain that people feel. It's just that they get that pain response from a much smaller stimulus than they would normally if their system wasn't so sensitized. And one of the mechanisms of how they think TENS can work is that it goes up the limbic amygdala pathway and has that very calming effect on the amygdala. So we talk about that fear-pain cycle. That's where one of the theories is that it helps to work in helping to break that fear-pain cycle as well.
Do you think, Fiona, then, you know, if we're talking about something like a cyclic menstrual period pain versus, say, somebody with chronic endometriosis who's progressing, or even chronic low back pain, who's progressing to that kind of, you know, steady pain the whole way around, would TENS be equally useful for both those populations, or do you see it being more useful in one or the other?
Absolutely. I think it's worth trying as part of your whole treatment regime for both types of pain, for sure.
Right.
So, and you know, we are seeing some good systematic reviews showing that.
Brilliant. And can I just ask, like, you know, what
more so probably for pelvic pain and back pain.
Sorry, can you say that again?
Sorry, I think we've got a delay. Sorry, no, I was saying I think probably more, certainly from the research, more appropriate for something like pelvic pain than for actual low back pain.
Okay.
So there's more research, yeah, backing for that. My knowledge, anyway.
Could you, could you just give us like an overview of the contraindications to TENS? Who is TENS not appropriate for?
Well, someone who's got a pacemaker, someone who has epilepsy, if you've got tissue where you're going to apply it, that any skin lesions on the tissue you're going to apply it to. It's generally accepted that we don't do it over the pregnant uterus, but obviously we're not going to have dysmenorrhea or necessarily endo pain when you're pregnant. So the main ones are someone with a pacemaker or epilepsy.
What about
sorry?
What about IUDs?
There's no reason why you can't use TENS because you're going externally.
Yeah, exactly. It's a question that comes up though quite a bit, isn't it? You know, but if
it
you
does probably more so for internal using intravaginal stimulation. But yeah, no, there's no, and in fact, if you look at the guidelines, we always used to be taught not to use it near metal or metal implants. So it's only active metal implants that are listed in the guidelines, and an active metal implant is a pacemaker or a defibrillator.
Okay. Right.
And yes, you can use them on a IPG, which is a implanted pulse generator, which is the active part of the sacral nerve stim unit, as long as it's turned off when you're using the, that's my understanding anyway, but I usually say to people, speak to the surgeon who you're working with the IPG for that, but you can certainly use it.
Brilliant. How does electrotherapy then fit into the biopsychosocial model? Because, you know, I've come across a couple of debates on social media, the great melting pot, that electrotherapy is outdated, that it's, you know, it's too tissue focused, too biomedical focused. But I think even from what you've said so far, it can be a really empowering, you know, way to improve self-efficacy and control, and, you know, an opioid-free potential return to a good quality of life. What do you think?
Yeah, absolutely. And just on the opioids comment there, you can actually, along with the treating doctor, I've seen quite a few people come right down off their opioids because we're replacing that input with the TENS. So, I mean, you've covered it there with psychosocial. You know, you've got the psychological aspects of self-management and being a little bit more in control. And yeah, certainly it's a lot of those arguments that you're talking about when people say, you know, are we with manual therapy? You know, we don't know what we're doing. But they use the term, we are neuromodulating. We're changing the input to get a different output. And that's all that TENS is. Down. Yeah, we're calming things down, and that goes through that whole amygdala, you know, fear pain cycle. So yeah, it's just another form of neuromodulation. It's certainly not what the all and end all, but it's part of your treatment, and you know, certainly something that patients can be doing themselves at home. And as some of these more recent systematic reviews have quite nicely stated, it's for where they get their pain, physically where on their body, and when they get their pain, so they can decide. Yeah, so there is, and Kathleen Sluker is someone who's very interesting to read a lot of her work. She's really, she and her team have highlighted a lot of the issues up to date with the research into TENS, and there's certainly some research that hasn't been very well done, and the general theme in the research now is we need to do better. But with a lot of them, what they were doing, they were comparing their outcomes of say opioids against TENS, and they were applying the outcome measures when it was maximizing the opioids, not the TENS, like to actually get your, you know, for example, if you're using high frequency TENS, the outcome measures need to be done whilst the treatment's being applied or soon after, because that's when it has its effect, not 3 hours later when it's gotten to the system. So there have been issues, but there's certainly a lot more, you know, people are heading towards more effective research, I think, in the area, but it's still in the systematic reviews, and there's been 2 that's been released this year, saying that it certainly shows statistical benefit for pelvic pain.
And so can I ask you then, like, just to put it into really practical terms, where do you recommend electrode placement, and how long should a session of high frequency TENS last for maximum benefits, in your opinion?
In my opinion, well, let's pull out the evidence on that.
Well,
In my opinion, well, okay, the way I like to describe it too, like technically we know that if we're talking the pelvic viscera, we're talking thoracolumbar and sacral nerve pathways. So you can try either or and see what works. Some women still find it better anteriorly over the abdomen, even though we're a longer way away from those nerve pathways. So the way I like to describe it, as long as it's on a feeder road that's going into the main highway, which is the spinal cord, and heading into town, which is the brain, as long as we're getting some neuromodulation along those pathways or those roads, you should be eliciting some effect.
great.
So depending on really where the woman just feels that she gets the most effect from it.
Yeah. And I suppose there'd probably be a stronger placebo effect maybe on the abdominal wall because it's right there where you're feeling it. Do you think that plays a role at all?
It could do. I can't say I've seen that actually stated in the literature, but common sense would tell you that for sure.
Yeah.
And it's really, I think people are a little bit scared of it because, as you said, I mean, if you were there in Victorian times, I went through uni in Georgian times, okay, so and we certainly did the full scope of electrotherapy. And yes, absolutely, it was probably overused back in the day, but the research wasn't there either. And that pendulum swung right over to, never put a machine on a patient. And it is now starting to swing back to where I believe it should be, somewhere in the middle as an adjunctive treatment that we can utilize as part of our management. And sorry, I've completely lost my train of thought there.
So would you say
there's sort of that middle
20
ground.
to 30 minutes? I mean, is that the sort of optimal time you would envisage being effective?
And that's what they're saying, yeah. And that latest systematic review by, I'm going to mispronounce this, Alboum Gabazon in 2020 this year, they looked at TENS for primary dysmenorrhea. And they did an overview, and they looked at what's right and what's wrong with the research, and a lot of that is based on, or very similar to Sluka's work, where they looked at where we have gone wrong. But their summary was from the RCTs that they looked at, that around 100 hertz at around about 100 width, and a minimum of 20 to 30 minutes on the part of the body that is working, where the pain is for the woman, or where she feels it's most beneficial. So that was basically, and to have it at the highest tolerable level, which is the other really important point that Sluka makes. It needs to be just, at that maximum that the patient can take, not this little sort of twiddly little, I can barely feel it. To be fully effective, and you've got to dose it right. And then that comes back to, you don't get the effect from your drugs if you don't dose correctly. So if your dosage is, 2 Panadol every 4 hours, you're not going to get the same effect if you only take 1 Panadol every 8 hours. But people seem to think that when you're looking at, stim applications that, that changes. It doesn't. We have to look at the dose. You've got to get the dose correct to get the right output. Or the right effect. And when I'm doing my running courses and talks, I sort of talk about that you dose your exercise. If a patient comes back to you and you have given them too many repetitions at too high a weight, then you're going to flare them up. And so the dosage of that is incorrect. So you pull it back. So it's all about the frequency and the amount. And it's exactly the same when you're looking at TENS applications as well. And one of just out of that paper, my favorite line was modulate if they accommodate. So anyone who's familiar with using TENS is people will what they call accommodate. So you kind of get used to the sensation, and that's when you need to turn it up. So you can either modulate by turning up the intensity, which is the milliamps, or you can use the burst or modulation parameters on the machine. So what they do is that it actually will cycle through different, say, frequencies or intensities as well. So it's kind of tricking things a little bit. Yeah.
And I think as well, then that kind of leads us nicely into another tool that we could introduce if there is a little bit of adaptation going on, the obstetricTENS.
Yes, and I'd love them to rename this because when it's not being used for obstetrics. I've actually got one here. It's just a normal looking TENS machine, but they come with the plungers. So when it's used for the obstetric situation, as you get a contraction coming on, the lady presses the boost button and it takes it up to a different level. You keep it there whilst the contraction's happening, and then when it's over, you press it again and it drops back down to the resting level. So what a lot of women, particularly when they get a lot of really bad cramps with their endo, etc., they find just hitting the boost button when they're having a cramp, they can leave it up at that different level. So essentially, yes, you're modulating it because you're changing from one level to another. It's just that, you know, for some women with endometriosis, the name obstetricTENS can be a little bit off-putting, but any TENS machine that will allow you to use a boost button and have the correct parameters in a program, you can use. So that can be a really handy way of getting on top of that sort of pain.
Yeah.
So there are some, sorry, I was just going to say, there are some machines that are specifically made for period pain, but I find generally you can't change the parameters in them. They've got set programs, and they do tend to be on the high frequency side, which our research is showing us that, you know, you're going to have more effect, but you can't play with those parameters, and set parameters don't always suit everybody. So it's within a range that you want to be able to experiment and find what works best for the individual. So that's why the ones that have a custom in it, you know, I find are better.
Yeah, and I think it's like it's kind of like elasticated trousers, isn't it? You know, they're going to fit everybody, but they're not going to suit everybody. So it's to have the skill and the knowledge to be able to tweak appropriately and to come up with a custom fit for the person who's in front of you, which leads me nicely into talking about your amazing course, because in my experience over the past 2 centuries of being, you know, involved in physio world, I don't know that electrotherapy is well understood or even well taught, unfortunately, anymore. And I think your course is brilliant because it takes these really, really complex topics of electrophysical agents, and I think what you do in your course is really make it accessible, but even more importantly, it's usable, but it's based on best evidence. So you've gone through all these millions of research papers and distilled them down into pearls of clinical wisdom. I mean, you just did it there now for us, you know, so high frequency, you know, so 100 hertz, you know, pulse width of 100, 30 minutes, either thoracolumbar or abdominal, boom, done, you know. And I find like that's what your course does for people working in this field of pelvic health particularly. And I really think from talking to folks who've done it, that they feel a lot more confident about expanding their toolbox into this. So from all of us in physio world, thank you for putting together this course, because it is not a small feat to put together something like this. So
it's not. Yeah, and it started off as a small thing, and it kind of took on a life of its own. But the whole and I mean, that was in response to all the questions I do get asked about, you know, TENS and eSTIM. And it's all about teaching principles, not protocols. Yes. So everybody wants the cookie cutter protocol. What do I do for this? What do I do for that? But what I try to do through that is teach you, if you can understand the parameters, then you have the confidence to play with those parameters and find the program that's right for your patient. Everybody does it with their exercise programs, and you know they've got the confidence to do that. And you're quite right. I mean, it's nobody's fault really. It's just that EPA came and went in fashion, so it was either taught really, really in depth back in the day, and then it, you know, less and less and less. So there's less people who know as much about it to be teaching it. Or you know, it depends on how much has been taught. So it depends where you trained and how long ago you trained as to how much understanding you would have.
Always asking a physio if they've ever done sporadic foot baths will give you an indication how back their training goes.
You can tell how old a physio is if they know the answer to that.
If they actually even know what thoracic foot baths are.
Yes, yes.
Not that we do, but you know, I hear that's what other physios do. So, you know.
Oh, yes, I've read about it somewhere. Yep.
In a journal somewhere. Okay, so I want to give a shout out to your course. Where can people find out more about your electrotherapy course? Because I think more people need to know about this and sign up and do it, because it will change your practice.
Thank you. Yep, either through our website, pelvicfloorexercise.com.au, and scroll down to course registration, and there's a link on there. The course is actually hosted over on Teachable, so that link takes you to Teachable, where you could go on to Teachable, and it's pelvic floor education with Fiona Rogers, and that's where the course lives at the moment. And I'm not sure when this will be going to air, but I am doing a very basic version of that in a few weeks' time for Pelvic Health Solutions. That's a live online, so that'll be a one-off. So if this is out by then, people could follow the same.
Early November, yeah.
Yeah. So, but yeah, the main course, the full course, sits over. The link's on the website.
And can I just also say, beware if you go to the pelvicfloorexercise.com.au website, because it is a treasure trove of many pelvic health things that you will want and see. And tragically, Fiona does ship internationally with her lovely husband and their team. So she has all sorts of goodies there. So do have a browse and see what marvelous things, including chopsticks, can I just point out as well. But all sorts of good things to be found on Fiona's website, as well as her amazing course. And Fiona, you may have a weights course coming out soon also, I heard through the grapevine.
Yes, the research is spread all over my floor at the moment. I've got piles of papers everywhere. I'm just trying to pull it all together. So I'm actually really excited about that one, because again, it's something that we get asked a lot. There's a lot of misconceptions about using vaginal weights. And again, I'm not someone who gives every single patient them, but for the appropriate patients, they can work really well, as particularly as feedback. And there is some really good research behind them. So I'm trying to dispel that whole myth of, you know, use vaginal weights and you'll become overactive, because it's not true.
So well, we'll look forward to that course. I'm presuming it will be a JDAG free zone, but we'll certainly have to get you back and talk maybe about some weight training for your pelvic floor muscles once that's up and running and you're ready to showcase it to the world. Is there anything else? If physios are nervous about introducing electrotherapy, I would say go have a look at Fiona's course. But would you say that, you know, looking at TENS, particularly for pain management, is a good place to start?
Absolutely. And get a TENS machine and, you know, put the electrodes on yourself and feel what it feels like. Yeah. And you know, try the different preset programs if that's where you want to start, and then maybe try some of changing the parameters a little bit and see what it feels like. So I actually believe you should do that before you try and pop it on a patient anyway. But you know, most physio clinics, whether it's you know, a pelvic health clinic or not, most physio clinics will have a you know, at least a TENS machine sitting around. So it's the same TENS machines that you're going to use, you know, elsewhere on the body. So
just before I let you go, does size matter when it comes to electrodes for TENS?
Yes, it does. And that's actually a whole section I talk about in my course, because you're looking at the surface area and the depth of penetration, etc. So you need an appropriate size electrode for the body part and for the size of the patient. So a larger patient needs a larger electrode because, you know, you've got more adipose tissue that will attenuate the signal, etc. And you know, you do need to have your electrodes excuse me, equal distance apart minimum. So if you've got a 5 centimeter square electrode, the next one has to be at least 5 centimeters away, otherwise you're going to get an concentration of the current. So it's knowing little things like that as well. But you know, have a little play on yourself and see what it feels like.
Brilliant. Fiona, thanks a million for all the knowledge bombs that you've dropped. And again, I highly recommend Fiona's course. Go check out the website, pelvicfloorexercise.com.au. And we will talk to you again, Fiona, when your vaginal weights course is ready to go. Bye for now.
Look forward to it. Thanks for having me, Michelle. Lovely seeing you.